Hi everyone, Assalamu alaikum. This is Dr. Tazeen here with another RRR series which the study EFOG and Study Medic has actually designed to optimize your exam preparation, and I'm here with you to discuss about the postpartum problems which the woman can encounter after delivery and how we have to deal it. So if you have not subscribed the YouTube channel of Study Medic, subscribe now so that you can enjoy this beautiful series of efficient learning and you can optimize your revision. So here I'm here to tell you first of all that success actually is the product of your daily habits, not once in a lifetime transformation. It means that you have to do the things on daily basis, and these baby steps, they can lead you towards success. When we talk about postpartum problems, actually what all the things you should know about postpartum problems, these are that you should understand that what are the causes and management of postpartum hemorrhage, to understand important postpartum complications which the female as well as the baby can encounter, basic concepts of puerperal sepsis and its management, neonatal assessment and resuscitation you should know, as well as birth asphyxia and its sequelae and how to manage it. These all are the important areas from the postpartum module. When we talk about the postpartum complications, first of all, we encounter actually that what actually we are encountering during the puerperium. So we have to keep in mind that the time following delivery, during which pregnancy induced maternal anatomical as well as physiological changes return to the non-pregnant state, its duration is understandably inexact, but it is generally considered to be 6 weeks after delivery. After each delivery, the uterus is usually slightly larger than before, and sonographically, the uterus and endometrium, they return to their pre-pregnancy state by 8 weeks postpartum. Early in the puerperium, sloughing of the decidual tissue results in vaginal discharge of variable quantity, and the discharge is termed as lochia, and this lochia contains erythrocytes, shredded decidua, epithelial cells, and bacteria. For the first few days, there is blood mixed red lochia, which is termed as lochia rubra. And after 3 to 4 days, lochia becomes progressively pale in color, which is known as lochia cirrhosa. And after 10 days, the less blood and more leukocytes are there, which due to that reason, it becomes yellow and white, which is known as lochia alba. So lochia rubra, rubra for red, cirrhosa, which is pale colored, and then lochia alba, which is white or yellowish in discoloration, which you have to keep in mind, which is actually important to know. Lactation actually involves a variety of hormones, including progesterone, estrogen, and placental lactogen, as well as prolactin, cortisol, and insulin. With delivery, the maternal serum levels of progesterone and estrogen decline abruptly and profoundly, and the drop removes the inhibitory influence of progesterone on alpha-lactalbumin production, and they stimulate the lactose synthase to increase the milk lactose. The posterior pituitary actually secretes oxytocin in pulsatile fashion and thus stimulates milk excretion from lactating breast by causing contraction of myoepithelial cells in the alveoli as well as small milk ducts. Milk ejection or letting down, which is your exam question, it is a reflex which is initiated especially by suckling and which stimulates the posterior pituitary to liberate oxytocin, and the reflex may even be provoked by an infant cry and can be inhibited by maternal fright or stress or depression. It can be inhibited. Colostrum after delivery is that the breast began to secrete actually colostrum. It is a deep lemon yellow liquid. It usually can be expressed from the nipples by second postpartum day. Compared with mature milk, colostrum is rich in immunological components and it contains minerals, amino acids, and more proteins, much of which is globulin. And however, it has less sugar and fat, and its secretion persists for 5 days to 2 weeks, and then it is gradually converted from transitional to mature milk by 4 to 6 weeks. Among vitamins, breast milk completely lacks vitamin K, and there is very less amount of vitamin D as well in the breast milk. Contraindications of breastfeeding can also be there, like if it is uncontrolled alcohol intake is there, okay, then it is, if it is infant with lactosemia, HIV virus is there, active tuberculosis is there, active breast cancer treatment is going on, herpetic lesions are there on the breast, and few cytotoxic drugs the mother is taking, like methotrexate, doxorubicin, and mycophenolate. So in these situations, actually, the breastfeeding is contraindicated. There are normal variations in the perpural psychological problems. There can be postnatal blues. The incidence is up to 80% in the first 2 weeks after delivery. The symptoms, actually, they comprise of fatigue, short temper, difficulty in sleeping, depressed mood is there. Tearfulness is common but usually mild, and it resolves spontaneously in the majority of the cases, and they are most common after first delivery. Perpural pinks are basically, the timing is 24 to 48 hours after delivery. It is actually the elevation of mood, a feeling of excitement is there, some overactivity is there, and there is difficulty in falling asleep. Symptoms that require evaluation as far as perpural psychological problems are concerned, they can be that if the symptoms they get worse beyond 2 weeks, if it is low self-esteem, guilt or hopelessness is there, suicidal ideas are there, panic attacks are there, mood changes are there, and disrupting the normal social functioning as well as quality of life is affected. So these are the things which needs the actually consultation, and they should be taken seriously, and they require further evaluation as well. Postpartum depression, in postpartum depression, actually there can be mild symptoms, for example 15%, or there can be major depressive disorder as well. The recurrence rate is up to 50%, and long-term depressive illness can also be there in 1 in 10% of the cases. While when we talk about more worsening of the situation, postpartum psychosis is among one of those. The incidence is 1 in 500 to 1 in 1000. Onset is usually day 5 to day 7, rarely earlier, and it differentiates from blues and depressions where the onset is actually earlier. Okay, it can be acute emergency situation and it may need hospitalization, and the recurrence rate is up to 25% in case of psychosis. There can be significant perpural pyrexia as well in the females. Okay, temperature of 38 degrees centigrade or higher, any two of the first 10 days postpartum. It is exclusive of the first 24 hours, which can be reactionary hemorrhage or which can be pyrexia. But after 24 hours, if it is there, then it should be considered seriously. A mildly elevated temperature is common in the first 24 hours in about 80% of the women who develop a temperature in the first 24 hours following a vaginal delivery. No obvious evidence of infection can be identified in these patients. What can be the various causes of perpural pyrexia? This should be kept in mind that it can be urinary tract infection, it can be endometritis or pelvic infection, mastitis can also be there, deep vein thrombosis can be there, episiotomy or cesarean wound infections can be there, spinal epidural site infection, atelectasis in case of general anesthesia, or Mendelssohn's syndrome can also be there, which is actually aspiration pneumonia, which should be kept in mind. The management of perpural pyrexia, it varies with the cause, but generally the general principles of the management of perpural pyrexia, they include admission to the hospital. Broad spectrum antibiotics should be given to the patient. Antipyretics should be given, and what actually is the cause of that infection, it should be sought out, and then it should be investigated, and further management depends upon the cause of that specific problem, that what actually is the cause, and then you can prescribe medication accordingly. For example, it can be mastitis. Mastitis can be a cause of pyrexia as well. It can be infective. It can be obstructive. The most common cause of infective mastitis is Staphylococcus aureus, which is followed by coagulase negative staph and Streptococcus viridans. Obstructive mastitis, it can occur if a blocked lactiferous duct obstructs the milk flow, which leads to distension of alveoli and inflammation, and pyrexia can also be there. Treatment can be that breastfeeding milk expression should be continued. Breast massage can be done. Hot compressions can be done. And flucloxacillin is the drug of choice. If the mastitis is worsening, then you can prescribe medication as well. And the drug of choice is flucloxacillin, which you should keep in mind. Breast abscess can also be one of the causes of perpural pyrexia. It is a complication of untreated mastitis. If mastitis is there and it is not treated, then it can be converted to breast abscess. The incidence is 10% of the women with mastitis, and gauged breasts can be there, okay, with localized area of swelling and tenderness. High-grade fever can be there. Diagnosis is based upon breast ultrasound. Treatment actually comprises of incision and drainage under anesthesia. And then flucloxacillin is the treatment of choice, and you can continue actually the breast milk expression from the affected breast, and then breastfeed from the opposite healthy breast should be continued in these cases, which actually can help. Then there is actually perpural sepsis, so which is among one of the most common situations which should be tackled appropriately and smartly. So here there is one question. Let's see that what the question says, and then we will move towards the options. Miss XY is brought to the accident and emergency department. She is unwell. She is para 1. Spontaneous vaginal delivery 3 days ago with rigid membrane, which are noted at the time of delivery. Okay, so her observations include pulse 128 beats per minute, blood pressure 80 systolic, respiratory rate 24 breaths per minute, temperature 39 degrees centigrade. She feels cold and clammy. She reports heavy offensive lochia. Which of the following antibiotics are the best suitable option to her? And the antibiotic options are oral co-amoxiclave and metronidazole, co-amoxiclave and gentamicin, co-amoxiclave and metronidazole, piperacillin, tazobactam plus metronidazole, piperacillin, tazobactam, and clindamycin. And what actually the answer says, that the answer is C. Administration of IV antibiotics within 1 hour of specimen of severe sepsis with or without septic shock is recommended as part of the surviving sepsis resuscitation care bundle. If genital tract sepsis is suspected, promptly early treatment with a combination of high-dose broad-spectrum antibiotics should be life-saving, and a combination of either piperacillin, tazobactam, or carbapenem plus clindamycin provides one of the broad range of treatment in cases of severe sepsis, which we should keep in mind. There are certain definitions, or there are certain categories of sepsis which you should keep in mind. First of all, sepsis is infection plus the systemic manifestation of infection. Severe sepsis basically comprises of sepsis plus there is sepsis-induced organ dysfunction and there is tissue hypoperfusion which is there. And in cases of septic shock, the persistence of hypoperfusion, it continues despite adequate fluid replacement therapy. The most common site of sepsis in the purpurium, it is the genital tract, and in particularly it is the uterus which can result in endometritis. The most common pathogens which can cause sepsis in the purpurium, they are actually Chlamydia trachomatis, which is most common in cases of endometritis and parametritis. Then it can be group A streptococcus, which is known as Streptococcus pyogenes. Always remember that group B streptococcus, that B is for the babies, so it is important in the neonates, whereas group A streptococcus, it is associated with puerperal sepsis. Escherichia coli can also be there, Staph aureus can be there, methicillin resistant Staph aureus can also be there, and Streptococcus pneumoniae can also be among the causes of these sepsis. There are certain risk factors for the puerperal sepsis which we have to keep in mind. These risk factors can be antenatal as well as antepartum. What are those antenatal risk factors which we have to keep in mind is number one, obesity, impaired glucose tolerance is there, diabetes is there, that should be kept in mind. Impaired immunity is there, the patient is immunosuppressed, she's taking some medications which are actually immunosuppressants. Anemia is there, vaginal discharge is there, history of pelvic infection is there, amniocentesis and other invasive procedures are being carried out that can be a source of infection, and they can introduce infection if the aseptic measures are not being followed. Cervical cerclage, then black or minority ethnic group origins, they are also more prone to the infections and sepsis. Intrapartum factors can be prolonged rupture of membranes, it can be vaginal trauma, and then it can be cesarean section which can put the patient at the more risk of sepsis. And in the postnatal period, it can be postpartum hemorrhage, it can be wound hematoma, retained products of conception, group A streptococcus infection with in close contacts or in the family members, that can also be a cause. What investigations to be carried out in cases of puerperal sepsis? Always remember that there is one set of general investigations and then there is one set which is actually dependent upon the cause. The general investigations, they include full blood count, urine complete examination, renal function test, C-reactive proteins can be there, blood cultures you have to carry out, serum lactate within the 6 hours of severe sepsis. Okay, then what you have to keep in mind, depending upon the cause, if you are suspecting upper respiratory tract infection, throat swab. If you are suspecting lower respiratory tract infection, chest x-ray, high vaginal swabs. If you are suspecting pelvic inflammatory disease, compression ultrasonography. If you are suspecting deep vein thrombosis, pelvic ultrasonography and CT scan. If you are suspecting pelvic abscess, and then wound swabs if you are suspecting that the infected wound is the cause of sepsis, that should be kept in mind. And the focus of infection should be sought and dealt with. This may be a uterine evacuation or by drainage of a breast wound or pelvic abscess. And then broad spectrum antibiotics should be given ideally within 1 hour of admission and severe sepsis. A combination of either piperacillin or tazobactam or carbapenem plus clindamycin, it provides one of the broadest range of treatment in cases of severe sepsis. If MRSA is suspected, then you can add vancomycin in place of clindamycin, which you should keep in mind. The antimicrobials and the limitations are there that co-amoxiclave, it does not cover MRSA, Pseudomonas, so this should be kept in mind. Then metronidazole, it only covers anaerobes. Clindamycin, it actually covers most streptococci, staphylococci, including MRSA. And switches of exotoxin production with significantly decreased mortality. it is not renally excreted or nephrotoxic. Piperacillin, tazobactam, and carbapenem, they actually cover most organisms except MRSA and renal sparing, in contrast to aminoglycosides. And then when we talk about gentamicin, which is given as a single dose of 3 to 5 milligram per kg, it poses no problem in normal renal function, but if the doses are to be given regularly, then serum levels should be monitored. Then in those cases, it can be nephrotoxic as well. For mastitis, you know that the causative organisms can be streptococci. So flucloxacillin and clindamycin is the drug of choice. And if the patient is allergic, then vancomycin and clindamycin can be given. Okay, if it is a cesarean section wound infection or IV cannula infection, then vancomycin and clindamycin is the drug of choice. And if there is any allergy, then clindamycin can be given, or teicoplanin, they are the alternatives. Cesarean section wound infection or IV cannula where it is actually caused by streptococci, flucloxacillin can also be given, clindamycin can be given, and if there is any resistance, then vancomycin and clindamycin can be given. In cases of endometritis, gentamicin, one dose immediately can be given, plus cefotaxime and metronidazole, and gentamicin, clindamycin, and ciprofloxacillin can also be the alternatives if any allergies are reported. In cases of pyelonephritis, cefotaxime plus gentamicin can be administered. Always remember that gentamicin one dose is not nephrotoxic. And if there are any allergies, then gentamicin and ciprofloxacin, it can be the choice. And if there are any other concerns, then gentamicin and meronum can also be continued for these situations. And this is actually the antibiotic spectra for obstetrics and gynecology, that how you have to proceed further for the antibiotics in various organisms, which you should keep in mind, and this can help you. Now, there are certain puerperal sepsis causes, and you should manage those causes, that if the patient is presenting with cough, purulent sputum, and dyspnea is there, it can be pneumonia. So investigations should be carried out for sputum culture and sensitivity and chest x-ray. Physiotherapy and antibiotics should be prescribed. If it is sore throat and cervical lymphadenopathy is there, that can be tonsillitis, throat swabs should be taken, and antibiotics should be prescribed. If it is headache, neck stiffness, epidural, after epidural or spinal anesthesia, there can be meningitis as well. So lumbar puncture can be carried out, and antibiotics should be prescribed accordingly. Dysuria, loin pain, and tenderness basically indicates pyelonephritis. So urine culture and sensitivity should be carried out, and antibiotics should be prescribed accordingly, as well as increased fluid intake should be encouraged for the patient. Secondary postpartum hemorrhage, if it is tender and bulky uterus, it indicates endometritis or retained products of conception. So clinical diagnosis and pelvic ultrasonography should be carried out, and antibiotics can be prescribed to the patient, and uterine evacuation should also be done if there are any sources of infection there. Pelvic pain, calf pain, tenderness is there. This indicates deep vein thrombosis. Chest x-ray should be carried out, and blood cases can also be carried out. Lung perfusion scan can be done, or angiography can also be, angiogram can be carried out. And heparin is the drug of choice which you have to give. If there are painful engorged breasts are there, they indicate mastitis or breast abscess. So clinical examination is important. Expression of culture and sensitivity of the breast milk of the affected side is important. You have to express milk if it is obstructive mastitis. You have to prescribe medication. Antibiotics, flucloxacillin is the drug of choice if it is infective mastitis, and if it is abscess, then incision and drainage should be carried out for these patients. So this is all about the important postpartum problems which can be there in cases after delivery. So you should be able to understand that what can be the various causes of these postpartum problems and how to manage it. If you go through this would be a quick revision for the series and this would help you in your exam. So subscribe the YouTube channel, click on the bell icon. So when the new series are uploaded, you get a notification and then you can enjoy learning. I wish you all the very best for your upcoming exams. Have a great day. Thank you.